Hi, in today's video, we'll be talking about confounding. Confounding is a very important EBM concept because its presence can very adversely affect the conclusions that we draw from a study. At the same time, its presence can actually be pretty subtle. Hence, if we don't look for it, we may sometimes miss it. So we'll start with defining what a confounder is. So a confounder is a variable that is associated with both the exposure or intervention and the outcome of interest. But of note, it is not part of the causal pathway. And the result is that this confounder then causes a spurious association between the exposure or the intervention and the outcome. So of note, the confounder is associated with the exposure, but it is not a consequence of it. This is what we mean by it not being in the causal pathway. So let's take a look at this example, right? So in this example, what we see is that the confounding variable here is hot temperature. And what we see is this spurious association between the rate of ice cream consumption and the number of sunburns, which is the outcome of interest, right? What we see here is that the hot temperature, which is the confounding variable, is associated with both the exposure, which is the ice cream consumption, but the nature of the association is not from the direction of the ice cream consumption causing hot temperatures. In fact, it is hot temperatures that increases the rate of ice cream consumption, right? And the hot temperature itself does prognosticate or does affect the outcome, which is the number of sunburns. Hence, it is important in summary to recognize that the confounding variable is associated with both the exposure and the outcome, but not involved in the causal pathway, and ultimately it causes a spurious association. And hence, if we are not careful to pick up the presence of confounders, we may make wrong conclusions from the associations that seem to be present. So this particular type of confounding by indication is something that we do see quite often in clinical practice. Confounding by indication occurs when the clinical indication for selecting a particular treatment, oftentimes it could include things like the severity of the disease, also affects the outcome. So for example, patients with more severe diseases are likely to receive more intensive treatments. And when we then compare across interventions, the more intensive kind of intervention will appear to be associated with poorer outcomes. So an example here would be, let's say in a disease, let's say autoimmune disease. In mild disease, you may then select for agents like hydroxychloroquine, and the outcome may seem more favorable. But versus, let's say, in more severe disease, we may be gunning for more potent agents like azathioprine, cyclophosphamide, and the outcomes may seem less favorable. And then if, let's say, we study the different types of intervention, we may then spuriously conclude that the more powerful agents are associated with poorer outcomes. But as we can see, the confounding variable here is actually the disease severity. And this is what we mean by confounding by indication. And we oftentimes see this in observational studies because we don't go about randomizing patients, right? So in observational studies, what we often observe is what happens in real life, and oftentimes the clinical determinants that decide and select for therapy could oftentimes be based on disease severity. So we then talk about controlling for confounders, which is something that is important. So the first step is to identify the presence of confounders, but the next step is to see how the study then attempts to control for the presence of confounders. So in RCTs, randomized controlled trials, what we often see is the use of randomization. So randomization is usually considered the gold standard for controlling for confounders because apart from controlling for known confounders, it also controls for unknown confounders through that randomization process. Out of the context of experimental RCTs in observational studies, unfortunately, we are faced with more limited options that oftentimes focus on the confounders that we are aware of. So this can be broken down into controlling for confounding at the design phase and at the data analysis phase. At the design phase, there are two main methods that can be done. Number one is restriction. So you basically limit the inclusion criteria. So for example, you only look at a certain age group or certain demographic. And what this does is that it eliminates, let's say, age away as a confounder, where you think that more elderly patients may be subjected to poorer outcomes. Matching can also be done. So we normally can match patients or subjects based on certain known characteristics, right? So this is at the design phase or the pre-analysis phase. At the data analysis phase, there are different tools that can be used. So the data set can be divided into different subgroups based on what might be known potential confounders. So it can be divided based on age, gender, disease severity, for example, and the analysis that takes place within these stratified subgroups. Of course, the problem with stratification is that you may then end up losing power because you are now dealing with smaller groups. We'll talk about in some detail regression analysis as well as propensity score analysis as data analysis phase methods of controlling for confounders. Instrumental variable analysis is a newer technique that's sometimes used, but will not be covered in this video. So firstly, we'll talk about propensity score analysis and then how we can use the propensity score in controlling for variables. So we begin first by defining what a propensity score is. A propensity score is basically a measurement of likelihood of receiving treatment or exposure based on certain covariates. So essentially what we are looking is that we determine certain covariates or certain characteristics that we think we predict getting the treatment versus, let's say, the control arm of things. And we then calculate a likelihood score based on these different covariates. So for example, we may take in things like disease severity, age, renal function, for example, that may then predict the receiving of a certain therapeutic option. So what do we do with this propensity score then comes next, right? So what we aim to do is to use this propensity score to balance the covariates across the treatment group and the control group, right? And there are several methods to go about doing this. We can do direct matching, meaning that we take patients with a certain score and we match them, and then we go down that pecking order so that you have sort of an equal number of patients in both groups and they basically have similar scores across the groups. You can stratify them based on the scores as well, or you can do some intermediate sort of method that involves weighting or adjusting, right? So instead of doing something so drastic like, let's say, matching, where you basically cull away all the other participants or subjects that do not match, you can use some form of weighting system that allows these participants to contribute a different weight in the overall analysis. So the limitations, however, I think fundamentally are that you can only control for known confounders as well as observed confounders, right? So if either let's say you have a known confounder that is not observed or not documented or not in your data set, then you can't control for that. Number two, then there are so many potential confounders and it is challenging to know every single one of them, and some actually may be unknown, right? And sometimes we may then run onto the other side of the problem where we try to include so many covariates. And from a statistical point of view, when many covariates are imbued into a model, this may then reduce the efficiency of the model. And that model as a means to adequately balance or control for the presence of confounding may paradoxically then become compromised. Certain methods like matching may also then result in loss of subjects, and this could affect the overall statistical power of the study. And there are also some criticisms that suggest that the use of propensity scoring and the different subsequent steps of things like, let's say, matching or even like weighting may result in systematic differences across the various groups that we are comparing. And this could then problematically result in the two groups not being adequately comparable at the end of the day. So regression analysis, on the other hand, is a statistical model that estimates the relationship between a dependent variable with one or more independent variables, right? So you have all these independent variables or potential sort of confounding variables or variables that may affect the outcome, and you plug them into the model. So there are different types of regression models depending on types of outcomes you're looking at. So for continuous outcomes, you use linear regression. For binary outcomes, you use logistic regression. And for outcomes that occur in a time-related fashion, we use proportional hazards regression models. So what the regression model does is that it estimates the association of each variable, each independent variable that is plugged in with the outcome after adjusting for the effects of the other variables. So sometimes when the regression analysis is used, what you would see in terms of the reported results is non-adjusted effects estimates, which is basically the pre-regression analysis that looks at the respective independent variables with the dependent variable, and an adjusted estimate that is basically after these various variables are all plugged into the regression model and adjusting for all the respective models, whether or not that effect estimate still remains. So if you see a very marked difference between the adjusted and non-adjusted estimates, then we need to be suspicious for the possibility of confounding, where some of the other variables that are in the model may actually have been confounders that may have resulted in a certain independent variable being spuriously associated with the outcome of interest. So this is the last slide, but I think at the end of the day, while there are no perfect methods for handling confounding, especially when it comes to observational studies, I think what's important is that firstly, that there is recognition of the problem of confounding, and there is some attempt at adjusting or controlling for these confounders, as well as acknowledgement of limitations of the results at the end of the day when it comes to observational studies because of the presence of confounding. So I hope that you found the session helpful. Thank you.